Hi, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of the Section of General Thoracic Surgery at Emory University Hospital in Atlanta. As we talk about a lot in cancer surgery, margins are critical. And specifically when we look at margins and types of resections, we can have an R0, an R1, or an R2 resection. So an R0 resection means that we have microscopically negative margins. In R1 are microscopically positive, and R2 are macroscopically positive margins. Hopefully that really doesn't happen that much. So when we talk about margins with lung cancer surgery, there are basically three margins that we look at. We have the airway margin, the vascular margin, and the parenchymal margin. When we're looking at lobectomies, parenchymal margins are really not that critical because you're taking the whole lobe out. And, unless the tumor is growing across the fissure, tumors tend not to jump the fissure, into another, lobe unless they're crossing over that. So the parenchymal margin is not that critical in a lobectomy or a pneumonectomy because you're taking out the maximal amount of lung you can with that tumor. Historically, we used to check the bronchial margin on all of our cancers, and we actually did a study years ago at Emory where we looked at several hundred patients and the bronchial margin, and I think we found something like a 2% positive bronchial margin rate, but the surgeon did not do anything differently with that operation when they found out intraoperatively there was a positive margin. So we'd send it off in the operating room and wait for the bronchial margin to come back. And that really started a trend where we don't check bronchial margins anymore because they're rarely positive. And even when they are, we're unlikely to go ahead and do more of a resection, which would be the whole lung coming out at that setting. So although the bronchial margin and all these margins are critical on final pathology, they're not as critical in the operating room. Where a parenchymal margin really becomes important is in segmentectomies. And it's been shown in multiple studies that you want a parenchymal margin equal to the diameter of the tumor or at least 2 centimeters. And that if you don't have that, that actually recurrence rates are higher in the first 5 years after surgery and survival is less. And that's why, we don't use segmentectomies typically for tumors over 2 centimeters. Because if you now all of a sudden, say you have a 3 centimeter tumor and you need a 3 centimeter margin, that's a 6 centimeter piece of lung tissue, that's essentially a lobe. And so that's where margins are critical though. And that's where if you need to decide if you're going to do a segment, you need to have an adequate parenchymal margin. We talked about wedge resections too, and margins are important in wedge resections. So if you're electing to treat a 1 centimeter lung cancer with a wedge resection, you need to have a negative margin. And the closer your margin is to the tumor, the more likely the possibility that you could have microscopic disease on the other side of your staple line. When I'm showing patients their tumors on CAT scan, I say, okay, you see a round ball there. It looks like a golf ball in your chest. But if you zoomed in with a microscope, you would see thousands of cancer cells randomly, arranged, mostly clustering in the middle where that round ball is, but some out on the periphery. And when we wedge that tumor out, if we leave some of those microscopic cells in there, that's going to lead to a recurrence. And you can see it on the staple line. You can see in other areas. And people actually looked at, are there ways to decrease those parenchymal recurrences? And there was a study where radioactive beads were placed on the staple line margin for wedge resections, or people have looked at radiating the margin. And so far that has not been shown to cause a decrease in local recurrence or a better long-term survival. The vascular margin is probably the least important. I mean, I mentioned it because the pathologist will put it in their report. Typically, when these cancers grow, they grow along the airway and along the lymphatics of the airway, so the bronchial margin tends to become the most important. There's always very specific kind of complex cases. Sometimes we'll have a tumor that's growing on to an upper lobe tumor growing on to the artery to the lower part of the lung. And sometimes if we don't want to take the whole lung out, we can go and actually remove that part of the artery going to the lower lobe and reconstruct it But in that situation, you've got to have negative vascular margins. So if you look at most cancers, the things that determine a worse prognosis would be spread and lack of a complete resection. So this is not just for lung cancer, but it applies for lung cancer. You want an R0 resection. And anything less than that is going to have a significant impact on survival. And that's why, it's very common when patients come to my office, they're like, what? You're taking out a third of my lung? That thing's tiny. Why don't you just snip it out? And the point is that because if you don't get good margins, you don't get all the lymph nodes out, then you're likely to get a early recurrence, and that's going to impact that patient's survival. And it seems kind of crazy, but if we look at the 5-year survival for stage 1 lung cancer, it's not great when you compare it always to other cancers like colon cancer and breast cancer, and that's with doing major resection. So these can be aggressive cancers, and we need to be kind of equally aggressive as when we're taking it out. It is pretty rare that I will get a frozen section on a standard lung cancer surgery case of lobectomy. And in fact, I can't remember the last time I did that. And the only time I really do is I go in there and I see something somewhere else, and I want to make sure it's not, the cancer has spread, and we'll do a frozen section for a biopsy of the lining of the chest, or a spot that we see in another part of the lung. And even people talk about, do you do frozen sections on the lymph nodes? So we didn't really get into this, and I kind of touch on it a little bit, but the standard lung cancer operation is a lobectomy plus a mediastinal lymphadenectomy or lymph node dissection. And so, what that really means is that when you're taking the lobe out, you're taking the tumor and the lymph nodes that are associated with that lobe. But the secondary spread of tumors is into the mediastinal lymph nodes, or the lymph nodes that surround the main windpipe. So the recommended operation for a right-sided lung cancer surgery would be a lobectomy plus removing the subcarinal lymph nodes, the ones where the airway splits, the right lower paratracheal lymph nodes, and even lymph nodes lower down kind of near the esophagus, or what we call the level 9 lymph nodes. And that is standard. That should be done for every right-sided lung cancer surgery. On the left side, we talked about we can't really access the paratracheal lymph nodes, so we can remove the subcarinal where the airway splits the right and left lung. And then we remove lymph nodes up where the artery that goes to the left lung crosses under the aorta. So that's the pulmonary artery aorta window, or we call AP window, and those are called level 5 lymph nodes. So those should be removed in every lung cancer case, depending on the side. And so, that's critical. And so some people will send that off for frozen section as they're doing it. I tend not to, because really our teaching is that if you find unsuspected metastatic disease, so say you take out some subcarinal lymph nodes, level 7, you send them off, and the pathologists say, oh yeah, we see microscopic cancer here. Most surgeons, unless it's some high-risk patient, would not stop the surgery, close the patient up, send them for chemotherapy. Most surgeons would move on, do the resection, and then refer those patients for adjuvant or chemotherapy and possibly radiation after surgery. And that's pretty much our teaching in a straightforward situation.